Hi, I'm Kristian Hargadon. I'm a biology professor at Hampden-Sydney College and was asked to provide sort of an update of where we are. I gave a similar talk on COVID-19 back in early May, and with the things rapidly changing, was asked to give kind of an update again. So for those that do not know me, I'm an alumnus of Hampden-Sydney College. I graduated in 2001, believe it or not, as valedictorian, and then went on to the University of Virginia for a PhD in microbiology, where I really specialized in immunology and tumor immunology in particular. But following my training there, then pursued a postdoctoral fellowship in viral immunology at the University of Virginia, studying influenza virus and interactions with the immune system. So I'm now back at Hampden-Sydney, beginning my 12th year in about a month, and am the college's resident immunologist and virologist. And so wanted to provide the community and honestly anyone who's interested in this video with an update of where we are right now. So with that said, I will jump right in. And my guess is I don't need to spend a lot of time on this first slide because I think everyone is well aware of the basics of coronavirus at this point, but I just wanted to hit on a few things that will relate to the rest of my talk. And so one of those is certainly how this virus spreads. And there are multiple modes of transmission. By far the most prominent is the airborne route of transmission. So contact with individuals who are sneezing, coughing, but honestly also just talking, the respiratory droplets that are expelled into the environment just through coughing and even breathing in some cases will transmit these viral particles. And hence the recommendations and strong guidelines that are now being put forth about mask wearing, social distancing, playing such a key role in preventing that major mode of transmission. Close personal contact also comes into play and in many ways relates with that airborne mode of transmission. So again, those public health measures are so critical to preventing or at least reducing dramatically the spread of this virus. Now the virus can also be transmitted by direct contact with contaminated objects. And again, this ties into the emphasis on frequent hand washing, very good hygiene, so that we're not contacting it, even if we are away from other individuals, but contacting on a surface and then putting our hands near our face. We want to avoid transmission via that route as well. There is evidence that it can be spread via the oral fecal route of transmission. This is much less common, and so really I'm going to be focusing on these top three modes of transmission today. Now, as far as the signs and symptoms of coronaviruses go, this list is expanding daily. CDC put out a new list just a week ago, and so the list I've got here is older, and I didn't update it simply because, again, it's changing daily. We're learning so much more about this. Obviously, the most common symptoms are those respiratory symptoms, the cough, the sneezing, the difficulty breathing, but obviously things like fever, GI-like symptoms. We're learning more about neurological symptoms. We're learning about the widespread systemic inflammation that can occur. Certainly in infants, we've seen this, but even in older individuals as well. And some of this goes along with the multi-system organ failure, the kidney failure, the pneumonia, the conditions that ultimately lead to death in many of the patients. So these are very serious symptoms that will certainly present problems for patients if they progress this far. Now, obviously, a big challenge right now is that there's no vaccine, and unless you've been under a rock for the last 4 or 5 months, you know that there's a lot of work going into vaccine development. And I am encouraged by some of the positive signs that they're seeing early on with those early phase trials, and certainly hopeful that we will have one available sooner rather than later. But the reality is there is some time lag there in the development of those vaccines. And so we have to think carefully about how we move forward in the absence of a vaccine. There are really no curative antiviral drugs either right now. There is remdesivir that they've had some success with that appears to shorten hospital stays for patients. The reality is we don't know if the patients that respond well to that would have recovered anyway and simply would have stayed longer in the hospital. So at this point, we can't say that we have a drug that we know will cure this virus, though a lot of work is going into that as well. So as we think about COVID-19, I want us to really think about coronaviruses in general, because there have really been 3 major coronavirus outbreaks in the history of coronaviruses, which date back at least to the 1960s, maybe earlier, but they were first identified in the 60s. And in fact, there are many strains that are constantly in circulation, these so-called typical strains of coronaviruses that transmit readily from person to person and cause nothing more than mild cold-like symptoms. They're easily resolved. They don't present certainly any serious problems in ways of mortality, and really even in terms of morbidity, just symptoms of the illness. They're very, very minor, and so we don't think much about them. But the three that have caused major problems, MERS-CoV, SARS-CoV, the original SARS, and then the 2019 nCoV novel coronavirus, which is a little bit older image here that we're now referring to as SARS-CoV-2, causing the disease COVID-19. These originate in a very different way, and that's in turn responsible for the complications that we see from them. So the way they originate is that they begin by circulating in animals, and then they undergo a mutation that allows them to jump from an animal to a human. And so rather than having a virus that is well adapted to humans and constantly in circulation that we've been exposed to as a population and have at least some level of immunity to that we can combat, all of a sudden when we jump from an animal to a human with this virus, our immune system has never seen this. And so complications can arise because one, there's no immune memory in check to fight this virus. And two, in some cases, we now know our immune system begins to react so strongly to it that it sort of overcompensates, and that produces some of the widespread inflammation that is damaging to the organs that are affected by this virus, which extend well beyond just the respiratory tract. This virus can affect many different tissue types in the body. So a little bit more about these three viruses. They all have a primary host being the bat, and then that primary host, typically a virus will evolve that can then infect what's called an intermediate animal host. And for the original SARS coronavirus in 2003, that intermediate host was the civet cat. From there, it acquired a mutation that jumped directly into humans. MERS-CoV, which causes Middle East respiratory syndrome, has an intermediate host of a camel. And then what most evidence is pointing to right now is that the intermediate host for SARS-CoV-2 is the pangolin, which I admittedly did not know what that was until a few months ago. It's an armadillo-like creature. And what we're learning is that it appears there was already a coronavirus circulating in pangolins. Another virus jumped from a bat into a pangolin. The two strains recombined and mutated in a way that when they jumped out, they could infect humans and infect them very, very readily. And so as we kind of look at these three major coronavirus outbreaks that have occurred, I'll start with the original SARS coronavirus in 2003, really late 2002 to 2003, initiated in China. You'll see that it was quite deadly, nearly 10% mortality rate, and it spread very efficiently. This R0 or R0 value refers to how many people an infected individual is likely to transmit the virus to and cause infection. So this is quite high, but it turns out that where this virus broke out, they really jumped on it quickly before it could get out of hand and basically got it eradicated through public health measures. We jump down to MERS, we see that this is extraordinarily lethal. Nearly 1/3 of patients die when they're infected with this virus, so much more lethal than either of the SARS coronaviruses, but it transmits much less readily. And so this virus actually has not been eradicated. It's been around for the past 8 years, but it simply has not adapted well to be able to be transmitted from one human to another. So you definitely don't want to get it, but if you do get it, you're likely not going to spread it very efficiently. And so now we come down to the bottom, COVID-19, where we really kind of hit the perfect storm here. We've got an R0 value that is higher than MERS and equivalent or maybe a little bit lower than the original SARS, but this virus got out of control before we could really get a handle on it. And so the impact of that has been data that is now worldwide over 15 million infections. and over 618,000 deaths. Now, if you just look at those numbers, that's about a 4.8% mortality rate. The numbers change so quickly, I can't stay on top of it hour to hour. But as of an hour ago, that's where the numbers kind of stood. So much less lethal than MERS, and the reality is that 4.8% doesn't take into account the asymptomatic individuals that we know are out there. So that number is much less lower, but it spreads so well and is infecting so many that the death toll is dwarfing what we've seen with the other two coronaviruses, and really anything in our generation, honestly. So again, just a little bit more about that R naught value. I'm rounding down to 2 just for simple math here. Again, what that's saying is that for every infected individual, they will transmit that virus to 2 other individuals. So 2 becomes 4, 4 becomes 8, 8 becomes 16. We get exponential growth of this virus, and that leads to the rapid outbreak, the rapid spikes that we're seeing in different regions at the current moment. And that's what makes this thing so dangerous. Now, the nice thing about the R naught value is that it's not set in stone. It is something that we can control and that we can change. We can bring that down. And I'm going to end today by talking about the ways that we can bring that down, that honestly at this point we must bring down. So before I move on to sort of these public health measures that are so critical, the other thing I want to do is to again emphasize how serious COVID-19 is, as if we need convincing at this point. I continue to hear comparisons to seasonal flu, and so I want to make those comparisons, but to do it in a way that shows that the 2 viruses really do not compare at all. And so again, that R naught value is where I'll start. It's essentially double for COVID-19. We all know how infectious seasonal influenza is. We see it all over come fall and winter on college campuses, within our school systems. When you get these kids in close environments, that virus spreads very, very quickly in packed communities. Well, COVID-19 spreads about twice as efficiently. And so that's certainly a serious issue to consider. Another sort of feature of COVID-19 that makes it very tricky to deal with is its incubation time. And that refers to the period of time from which you are first exposed to that virus and your symptoms present themselves. For flu, that's anywhere from 1 to 4 days. For COVID-19, it ranges anywhere from 1 to 14 days. This means you could have the virus, one that we know is highly transmissible, and you could have it for 2 weeks without knowing you have it at all. And in that meantime, think of who you come into contact with over a 2-week period. That's who you can be spreading that virus to. And again, that 14-day window does not take into account the asymptomatic individuals who will never develop symptoms, that we never know are out there and that can be transmitting this virus. This is really scary to think about, and the statistics are going to continue, I think, to scare you. But my hope is that as we wrap up and talk about what we can do about them, we have it in our power to make things less scary for us, hopefully. Again, as we think about the morbidity associated with these viruses, flu produces symptoms that result in about 2% of infected individuals having to be hospitalized. For COVID-19, that's about 10-fold higher. Almost 20% of infected individuals will have to go to the hospital at some point. That number, again, may come down a little bit as we go, as younger individuals are getting sick more recently at higher levels. They tend to handle the virus better, but I emphasize the word tend to. That's a generic rule. It's not a hard, fast rule. We know individuals in their teens, in their 20s, in their 30s, in their 40s who are hospitalized, who do succumb to this virus, who do die from this virus. And so it's something very serious that this virus has such a high morbidity associated with it. And then in terms of mortality, what we certainly think the most about, For seasonal flu, it's typically around 0.1% or lower that will die from seasonal flu infection. For COVID-19, I've put a range here. This is an older slide from CDC, 1 to 3.4%. Again, I hate to put an exact number on that. We don't really know because we know there are a lot of infections out there that we're just not catching right now that are asymptomatic. I think right now the most accurate estimates are probably at about 1%, which still put this well above seasonal influenza. And honestly, even if that number were to come down, it doesn't really matter what the percent is because so many people are infected. We see what the death toll is. The last thing I'll kind of mention as I compare these viruses here on this slide is what this means in terms of hospitalization. We know that we're putting 10-fold more patients into the hospital when they're infected with this virus. Not only are they going there and taking up hospital beds and resources at hospitals, they're staying much longer than a typical individual who would be infected with seasonal flu and would have to be hospitalized. Average stay of about 12 days compared to about 3.5 for seasonal influenza. So we're looking at 3 to 4 times longer stay in the hospital on top of more patients being hospitalized. This is how our healthcare system quickly gets maxed out beyond its capacity. This is where we run out of personal protective equipment. We run out of ventilator support. We run out of ICU beds. And this is what is causing healthcare professionals to have to make the unfathomable decisions of who am I going to attempt to save? I've got 1 ventilator left. I've got 1 bed left. Which of these 2 or 3 patients do I think has the best chance of making it and that I put there? Knowing all along that they might be wrong in that decision and lose both or all 3 of those patients. I've got colleagues working in these healthcare settings in New York when things were so bleak there that it was just, terrifying to talk with them and know what they were going through. They were describing it as a war zone and just the emotional trauma of having to try to make those decisions. These are things that we really need to avoid and that we're on the verge of honestly now seeing in multiple locations what we saw in New York several months ago. So now in Florida, Arizona, Texas, California, this is where we're hitting if we don't get on top of things very, very soon. Last slide, I think that will really illustrate the fact that there's not a comparison between influenza and COVID-19 in terms of mortality, kind of getting away from percentages. Let's just look at the real numbers. So this is data collected from the CDC over the last 10 years or so, looking at seasonal influenza deaths. And when I presented this back in May, this COVID-19 bar was sitting right around 80,000, right where my mouse pointer is right now. And I even got the question at that time, well, that's not much worse than, one of our bad seasonal flu years at that time. So a couple of things to point out about that. This is over the course of a year for influenza, where a few years ago we had 65,000 or so deaths. And when I presented this in May, we were 3 months in to COVID-19. Well, look at where we are at 5.5 months in. We're now at over 142,000 deaths. The other thing that I mentioned at that time that I'm going to do again here now is that this comparison that I'm showing you is actually the inaccurate way of making this comparison. And I present it this way to show you what I'm seeing in a lot of places that is very misleading. So why is it misleading? Well, the way that CDC reports its influenza deaths is as estimated deaths. They know that they have patients that come into the hospital and that are diagnosed with flu and die. Those are lab confirmed deaths. They also know that there are many patients who die from flu in the public that simply because of lack of healthcare access are not getting into the hospital being diagnosed. And they have algorithms for estimating these, and that's what these bars represent here. For COVID-19, that is not the way deaths are reported. Deaths are reported as either lab confirmed cases or as probable deaths, probable being defined as someone who was exposed to a confirmed COVID-19 patient and presenting with symptoms of COVID-19 who then dies. So very likely to be a COVID-19 related death, and in many cases later post-mortem being confirmed and converted from probable to lab confirmed. So the vast majority of these are lab confirmed COVID-19 deaths. And so if we make the accurate comparison of deaths in that way with influenza with what is lab confirmed, this graph now looks like this, where we have dwarfed flu mortality by comparison with COVID-19. And again, the reality is we could estimate COVID-19 deaths. We know that those are out there not being confirmed and documented as well. And so the reality is this bar is actually much higher than I presented it right here. And then lastly, this is after all we've done. You know, we have implemented some measures that we never do for seasonal flu. When we shut down the economy, when we have tried, and I emphasize tried to implement social distancing and face coverings, mask wearing, those are things that we do not typically do in the United States for seasonal flu. And again, I will emphasize that we have tried that because the point I want to make today is that we've not done it well as a nation. And that's sort of why we're in the mess that we're in right now. And we need to really readjust how we're thinking about handling this going forward. So I know a lot of that sounds really depressing, and it depresses me to see some of how we've gotten to where we are right now. But I do want to try to encourage people out there. We actually can do something about this. We can still get ahead of this. And so what is it that we can do? Well, there are a few things that I want to talk through here kind of in the latter half or quarter of this presentation today. And that's that we've got a few options here. I'm going to start in terms of social distancing. The first option I'm going to pay lip service to for about 10 seconds because I don't want us to think about it at all. That's that we just let things play out. And I don't want to say that we have fully done that, but in many locations, that's largely what has been done, at least by some individuals. And it's a big problem. If we let things play out and we don't start implementing public health measures, these blue individuals are susceptible, the red individuals are infected. We are going to continue to get massive, massive infection. And that means we're going to lose a lot of people that we otherwise would not. So let's move away from that. What's the ultimate goal? Well, we need a vaccine. And as I mentioned earlier, that is well in the works. And I'm optimistic based on, again, some of the trials that I've seen reports of already, that we are going to have a good vaccine much sooner than historically has been possible. The scientific community is really coming together, and technology is at a place where I do think we're going to have a good vaccine sooner than later, but that sooner than later still means very late 2020 and honestly, probably realistically sometime in 2021. So we've got some work to do in that time. But what a vaccine will do is these light blue individuals will now be immunized and protected from the virus. If there are individuals who do not get the vaccine, they will be susceptible. Some of them may get it. If we look at this individual up here, if they get it, but there's a lot of protected individuals around that person, they will not be able to spread that virus within the community. And so this is where herd immunity comes in. These unvaccinated individuals down here are essentially protected by the barrier of vaccinated individuals in the community who don't serve as hosts to propagate that virus. So it doesn't mean that no one will get infected and that no one will die if not everyone is vaccinated. That will happen, but at a much, much lower level than what we're seeing right now. And obviously, again, this is months away, so we need to do something in the meantime. And this is where our public health measures make a really, really important impact and are really our only way of combating this virus until the vaccine or until curative therapeutics are available. And so here we're kind of illustrating social distancing by boxes around these individuals. So here, someone who's infected and is aware and it's isolating can't spread that virus to someone else. If individuals who are not infected, but who don't have to be out and try to stay in as much as they can, well, in that case, they're protecting themselves from others who are out in the community who might be infected. And so again, you know, this isn't the solution or the sole way to fix this, We might still spread virus, but we're going to do it at a low level by implementing this sort of distancing practice. And again, there's great evidence that 6 feet, does a lot. And if you can do further, you should do further in many cases. Again, a slightly older graphic. So when this says now, this was sort of referring to the peak of things in New York City. Without social distancing, this is where we were in terms of infections, and we had maxed out the healthcare system. So just by implementing social distancing, we can bring this down. One person without social distancing and an R0 value of 2.5 infects 2.5 individuals over roughly a 5-day period. Within 30 days, that's 406 cases, okay? Each of which can infect 2.5 people within 5 days. Things balloon. This is why contact tracing is extremely difficult when you've got infections at this level. But we can reduce that level very efficiently just with 50% less exposure. That number now goes to one person infecting 1.25. Over 30 days, we've exposed 15 people. If we reduce our exposure by 75% through social distancing, one person over a 30-day period is going to lead to 2.5 infections. It is very easy to contact trace when infection level is that low and prevent propagation of the virus. It is impossible when it's at this stage. We don't have the resources to do it. We don't have the testing capacity to get results. We're hearing about these lags in testing results right now. It's because our infection levels are so high and testing is at the level that it's currently at. So, but if we can bring this down through social distancing, we can reduce infections, we can allow our healthcare systems to be at capacity and better treat those few individuals who come in to the hospital. All of that is just through social distancing. Well, what about masking? Masking has unfortunately, for some unknown reason, become a very political topic right now. There's nothing political about this. The virus doesn't care what your political beliefs are. It wants a host to grow in. And the virus is loving the United States' response to its presence so far. We need to make the US an unhappy place for the virus. And masking can go a long way in doing that. There is great evidence for this now. Early on, it was that it prevented the wearer of the mask from transmitting the virus in their respiratory droplets. There is also evidence now that it protects the person wearing the mask. And as I like to tell people, you do not need a PhD in microbiology or immunology or virology to imagine that a barrier over your face and nose is some level of protection. And certainly it varies by the type of mask you wear, but anything is certainly better than nothing. And again, the science now supports what in my view has always been kind of the common sense approach to this, but there is scientific evidence now that they indeed make an impact for both the wearer and the uninfected wearer as well as the infected wearer. So without masks, probability of transmission is extremely high. If you're uninfected and wearing a mask, again, it's not complete protection, but it is some level of protection. You're reducing your risk of exposure from infected individuals. The infected individual, and people have probably seen the videos now, if you cough or sneeze with a mask on, those respiratory droplets do not travel very far. And so you're certainly protecting susceptible individuals and reducing risk even further. And where we really need to be is sort of down here towards the bottom. Both infected individuals and uninfected individuals wearing masks, dramatically reducing risk of infection. And if you're doing this while implementing social distancing, there is a very, very low risk of infection. And you are going to really dramatically reduce spread within communities and keep infection at a level that we can deal with in many, many ways. You know, before those studies came out, I showed this slide back in May. This was data collected in late, I believe, just sort of providing anecdotal evidence for masks. And you can see in countries where wearing masks is more socially acceptable, South Korea, Japan, Singapore, Hong Kong, individuals in these countries do this routinely during outbreaks. You can look at these curves that were flattened very early in comparison with countries where wearing masks is much less socially acceptable or just less routinely practiced. These curves were sort of skyrocketing at that time. Some of these other countries have brought this down since then. Others, unfortunately, have not, because they've not fully embraced these public health measures. And so this kind of brings me now to, why are we currently on July 22nd in the mess that we are in? I want to compare sort of what has happened in the United States versus what's happened in the European Union, where the virus actually started earlier. Very early March, we start to see this virus beginning to be detected and rapidly, exponentially increasing. And we see that weeks later, the same, identical pattern. These lines overlap one another. We see this exponential growth rate. All right, things start to differ a little bit after that exponential increase. Well, why was there a difference between the two? The United States shut down the economy. We started hearing about social distancing and wearing masks at some level. And as I said earlier, unfortunately, we didn't do it the right way. We didn't do it the way the European Union did. When they shut down, I mean it, they shut down. People did not come out of their homes other than for an essential grocery run once every 2 weeks. When they did come out, they were socially distanced and they were wearing masks. And so, as I like to say, the European Union did not flatten the curve, it crushed the curve. It brought this case count down to a very manageable level, and a level that has allowed them to resume activities at a much higher level of normalcy than honestly we're able to do right now. And at a level where when they see a small blip like this, they have the ability to contact trace. They have the ability to treat patients effectively and not max out their healthcare systems. And so they have not eradicated the virus, but they crushed the curve and they have stayed flat at a very low level. Unfortunately, we did things halfway, and I don't think this is a surprise to anyone. It's not a political thing for me to say that there's not been a national response. This is just fact. States have handled things differently, and unfortunately, we see what's happened in some of the states that loosened restrictions too early or did so in a way that did not emphasize the importance of the public health measures once reopening. We all had to reopen. I think we recognize that, but we didn't quite do it the right way. And when you're starting at an infection prevalence at this level in a population, if you start getting spread, it balloons out of control quickly to where, as of July 6th, we were at 40-some, probably 50-some thousand cases per day. And again, if you've been following the news, you know that now 2 weeks later, we're averaging about 66,000 cases per day in the US. We've hit over 70,000 3 times at least in the last week. So we have a major problem. All we've done is to make things harder on ourselves at this point. But we have a problem that we know public health measures will correct, can correct, and will correct if we implement them across the board. And that's kind of the optimism that I want to leave us with today. There's nothing optimistic about where this curve is right now, but the fact that we know there are things that will work, if we just do those things, we can get this curve, we can crush the curve as well, even though it's at where it is right now. So just some final thoughts on how to move forward. And most of these are just sort of rewiring how we think as a society. So the first is that resuming activity and social distancing are not mutually exclusive things. We've heard this phrase, new normal. We need to adopt this and not really adopt, but embrace the idea of a new normal for a while. And that for a while is really until we get an effective vaccine. But we can do things. We can open businesses in a safe way, in some way. We just can't go back to what we were doing back in January and February before we knew we had an issue. Again, just sort of kind of rewiring how we think as a society. And a lot of these points I'm making are based on just comments I've heard people say over the last few months. So the first thing I want to emphasize is that it is okay and it's not offensive to stand 6 feet away from someone to whom we are speaking. In fact, what we need to be thinking about is that standing closer or shaking a hand or giving a hug, which are things that certainly I like to do as an employee at Hampden-Sydney. I want to shake the hand of every parent and student that comes to class when our students matriculate in a few weeks. But that right now is the incorrect or offensive thing to be doing. And if we kind of appreciate things in that way, that we're actually being much more respectful of others by maintaining that distance, we can be as welcoming without doing those things that we've always done. And I gave the Hampden-Sydney example. Again, this is for our world right now, very honestly. The other thing in terms of wearing a mask, as I said earlier, there's nothing political about that at all. So we just need to get that kind of out of our mindsets. But also wearing a mask doesn't mean that I'm scared of you or that I don't trust you. It really means that I care about you and those who you come into contact with. And that's a big point of emphasis that I've tried to make, thinking about who others come into contact with after we've spoken with someone. We must get away from thinking, just so direct, okay, I'm speaking with this person and that's who I have to think about. And well, this person is in an age group that's much less susceptible to the virus. Again, as I said earlier, every age group is susceptible to very severe complications or death from the virus. Now that said, there are some generalized statistics out there that certain age groups, college age students, individuals in their 30s and knock on wood, 40s like me, I feel like I'm statistically in an age group who's much less susceptible to severe complications. But even if I were not to have a severe complication, who am I going to come in contact next? Or who are you going to come into contact with next? And we need to start thinking not just, 2 moves ahead in chess, but 3, 4, 5 moves ahead in chess. If I leave Hampden-Sydney and go to Walmart in town, am I going to turn the corner and bump into an 80-year-old with underlying health conditions who's highly susceptible to this virus? We all really need to think in terms like that. And we all, based on what we know about asymptomatic carriers now, we need to adopt the understanding that we could all be asymptomatic carriers. We need to think of ourselves as harboring this virus because in many cases, some of us may be harboring that virus. And so we've got to wear this mask, do the social distancing as a way of demonstrating how much we care for all of those around us, including those we don't know. A point that I did not put up back in May, but I think is really worth emphasizing now, there is no such thing as overkill at this point in terms of implementing these safety measures. If we can end up in a few months' time saying that what we did was overkill, we did the absolute right thing, and we will have been successful in combating this virus. And then lastly, we all feel isolated. Certainly that's clear. And I, more than anyone, want to get back to our not new normal, but our old normal. We all want that. But even though we may feel isolated, we've never depended on each other more for this. And the longer we take to implement these kind of measures I've discussed today, the longer this is going to drag out. I gave a similar presentation yesterday and kind of made the statement that I would much rather be really miserable with these safety measures for a couple of months than to be moderately miserable for a year. But that's the reality of what may indeed happen. So all of these points here, I've given a few Hampden-Sydney examples, a few examples outside of Hampden-Sydney. Honestly, this is for our world in general, and particularly our country where we have such a problem. But I do want to finish with a couple of just take-home messages to my fellow Tigers out there. Hampden-Sydney, and those that are coming in, those that are there now, those that have been through our gates and are out in the world. And the first is, we've got this catchy motto on our gates in Latin that when you translate, essentially means enter as boys, leave as men. And I think we really need to think about changing that motto for the time being to, we need everyone, this is not directed to just our students, but everyone to enter as men. And when I'm not directing this to students, certainly that goes to women as well. Enter as men and women and leave as leaders who set an example for our community, for our state, for our country, and for our world. Hampden-Sydney students and former colleagues are all over, and we can set an example with what we implement here. And the other sort of catchy phrase that we have that is something that I think is so important to our mission, it's in fact part of our mission statement, is that we form good men and good citizens, again, in terms of our students. And again, we must all be good citizens at this point. Our students that come in, our faculty, our staff. So this good citizens, again, good men and good women we're referring to here. Our community and our world have never needed us more. And nothing says good citizenship than taking this virus seriously and implementing the things that we know will allow us to do the things that we are good at doing at Hampden-Sydney in a safe and effective way. And so with that, I am going to wrap things up here. Thank you all.